Hi all. Today I will be discussing about the basics of antibiotics in ICU. Antibiotic is one of the most important drug used in the intensive care unit. But the knowledge about the antibiotic is not very well among the young intensivist or the trainees. The most important concern in using antibiotic, which is different from the OPD patients or the outdoor-based patients, is the change of the pharmacokinetics and the pharmacodynamics of the ICU patient. One of the also important concern is the selection of the antibiotic for the source of infection. So the proper selection of antibiotic for proper source of infection is also very important. So in this video, we will be doing in parts. We will be covering antibiotic in part by part, and we'll be looking into each part into minor details. So here I am sharing my screen for the antibiotics. Sorry for a little delay. So antimicrobials in ICU. Antimicrobials is one of the most common drug, as I say, used in intensive care unit. It is the drug rather in almost 90% of the patients admitted in the ICU. We will be dealing with the basics of the antibiotics, the pharmacokinetics, the pharmacodynamics. Then we will be reading about the resistance pattern of the antibiotics. And lastly, the IDSA guideline, which is most prevalent or which guides our antibiotic therapy. Starting with the difference between the gram-positive and the gram-negative bacteria. We have two types of bacteria, gram-positive and gram-negative. The most important difference between these two bacteria are the thickness of the peptidoglycan layer. In the gram-positive bacteria, the peptidoglycan layer is multi-layered and is thick-walled. And in the gram-negative bacteria, the peptidoglycan layer is thin and a single-layered, but it has an additional covering of outer membrane along with the peptidoglycan layer. So within the peptidoglycan and the outer membrane is the cell membrane. So most of the antibiotics, or the most commonly used antibiotics, beta-lactams, acts on the cell wall of this bacteria. So as the cell wall of the gram-positive bacteria is thick and multi-layered, so it retains the initial stain in gram staining and colored violet, while as the cell wall is thin, in case of gram-negative bacteria, it cannot retain the initial stain and it takes the secondary stain, so it becomes pink in color. So anything given violet is gram-positive, anything given pink is gram-negative. We will be coming in more in details, and the lipid content is very low in case of gram-positive bacteria, and the lipid content is 20 to 30% in case of gram-negative bacteria. And another most important thing, the difference between these two are the presence of lipopolysaccharide, which is the trigger for the septic shock or endotoxemia, is the lipopolysaccharide, which is present on the cell wall of the gram-negative bacteria. So this is the color which I said. The violet color is for the gram-positive. The pink color is for the gram-negative. So if you get this type of images in the exam, the violet color will be of the gram-positive and the pink color will be of the gram-negative. Also, we have some encapsulated bacteria. Among these, the most famous are the gram-negative. Haemophilus influenzae is involved in the community-acquired pneumonia. Neisseria meningitis causing meningitis, and Pseudomonas and Klebsiella are very common friend of the intensivist, causing nightmares to the intensivist, especially the Pseudomonas aeruginosa. Gram-positive, the most common are the Streptococcus and Staphylococcus. They are the example of the encapsulated bacteria. So they are involved in different type of disease, starting from the skin and soft tissue infection, meningitis, pneumonia, and other bloodstream infections also. Coming to the important classification of the gram-negative bacteria. The gram-negative bacteria, when growth on a McConkey agar, gives to lactose gives rise to the lactose fermenter and the non-lactose fermenter group. The lactose fermenter group mainly consists of the Klebsiella and the E. coli, where the non-lactose fermenter group mainly consists of the Pseudomonas, Acinetobacter, Stenotrophomonas, Proteus, Salmonella, Shigella, and Burkholderia, those which causes more serious infection, and those are mainly the headache for the intensivist. While the lactose fermenters are relatively causing less severe infection, Escherichia E. coli, Escherichia coli, and Klebsiella pneumoniae. Coming to the gram-positive, the classification mainly goes by the cocci and the bacilli. Normally, we say in our ICU GPC or gram-positive cocci or GNB, gram-negative bacilli. So the gram-positive cocci may be obligate anaerobic and aerobic. The anaerobic cocci are the Peptostreptococcus, which are mainly involved in the formation or the causation of the aspiration pneumonia. The cocci and aerobic cocci are again divided into catalase negative and catalase positive. The catalase negative being the streptococcus, the catalase positive being the staphylococcus. So the strep is always catalase negative. Coming to the classification, it is alpha, beta, and gamma hemolytic depending on the hemolysis on the blood agar. So group D streptococcus is known as enterococcus. So if it is asked whether the enterococcus is catalase positive or catalase negative, then the answer is the enterococcus is catalase negative. The catalase positive comes to the staphylococcus. The staphylococcus is again divided into coagulase positive and coagulase negative. The coagulase positive being the Staph aureus, one of the most notorious organism in the ICU, and the coagulase negative are generally the common cells in the skin. Coming to the bacilli, gram-positive bacilli are not commonly found, but if found, they may be Mycobacterium or Nocardia. To note here that the acid-first bacilli is not only Mycobacterium. In immunocompromised individual, you can get a modified acid-first stain positive for Nocardia also. Coming to the obligate anaerobic bacilli and the actinomyces and bifidobacterium, they are not very commonly found, but which you can found is the listeria. Listeria can cause meningitis and above age of 60 in patients, mainly in the immunocompromised zones. So the listeria is a commonly gram-positive bacilli. So if in an infection, if you are told that on gram staining, in the meningitis, if you are told that in a gram staining you have got a gram-positive bacilli, then you may think of the listeria. So after gram-negative and gram-positive, we come to the classification of fungus. The fungus is mainly classified into yeast, mold, and the dimorphic. The yeast is also of two types, true yeast or Cryptococcus, or yeast-like with pseudohyphae. So the yeast, which is true yeast, is the Cryptococcus, mainly involved in the causation of the meningitis. But the yeast, which is yeast-like with pseudohyphae, is the Candida. Often we get call from the microbiology and we got a yeast with pseudohyphae. Many a times residents start thinking it's the word hyphae means it will be mucor or aspergillus. It's not like that. It's a pseudohyphae. It's during the reproduction. It doesn't get detached from its mother cell. So it forms like an hyphae, which is not a real hyphae, and it is called the pseudohyphae. The mold on the other side is classified into two parts, accepted hyphae and septed hyphae. If it is a septed hyphae, then it's the aspergillus. And if it's an accepted hyphae, then it's a mucor. The dimorphic fungus, dimorphic why? Because it's a combination of yeast and mold. It remains yeast at a higher temperature of 37 degrees and it forms mold at a lower temperature of 22 to 25 degrees centigrade. The example of being the histoplasma and blastomyces. But the most important concern for our ICU is the top four: Cryptococcus candida, mucor, and aspergillus. So coming to the first question, we have already read which of the following is a lactose fermenter: Pseudomonas acinetobacter, Klebsiella salmonella. A, B, D are the notorious. C is also notorious, but the most notorious are the A, B, D. So the C is the lactose fermenter, and others are the non-lactose fermenter. Coming to the question number 2, which of the following is a gram-negative diplococci? So the important question is gram-negative, but it's a cocci. Normally we say gram-negative bacilli. So this is a gram-negative diplococci causing and meningitis. So the gram-negative here is B and C, among which B is the bacilli and C is the cocci, and it's a diplococci. So you can get a question on meningitis showing that the gram stain is showing diplococci. So the gram-negative diplococci answer is Neisseria. You have to memorize or remember for your exam purpose. 65-year-old man came to the ICU with fever, coughs, SOB, sputum stain and culture stain. Below is the gram staining. So we have read the violet. Violet is the gram positive. So here the color is the violet. And in gram positive, this is diplococci. So in gram positive, if you are getting a diplococci, then it is Streptococcus pneumoniae. So the gram positive diplococci is Streptococcus pneumoniae. If it had been appear in bunch of grapes, then we would have a bunch of clusters of grapes, then we would have thought of Staphylococcus aureus. So this is a fourth question. This is a fungus with an asepted hyphae. So as we have seen, asepted hyphae, blackish discoloration of the intestine causing invasive mucormycosis. There is a reverse halo sign in the CT scan. There is a hyperdense surrounding a region. So this is the reverse halo sign. The opposite is the halo sign. So this is the diagnosis of invasive mucormycosis. So you can get this type of questions in the exam, especially in the group of NEET SS. So coming to the definition of antibiotics, antibiotics are the substance which was produced by the microorganism, where the chemotherapeutic agents were restricted to the synthetic compound. But nowadays, this classification doesn't separate these two. So both synthetic as well as naturally obtained drugs comes into the umbrella of antimicrobial agents. So the topic of my presentation was antimicrobial in ICUs. So antimicrobial agent consists of both the naturally producing and the synthetic compounds. Coming to the history, we all know Alexander Fleming found a diffusible substance elaborated by the penicillium mold, which could destroy the staphylococcus on the culture plate. Once he went into the vacation, when he came back, he saw something growing into the plate, which was inhibiting the growth of the staphylococcus. He named that substance to be penicillin. But later on, it was popularized by Chen and Flore, followed up this observation and culminated in the clinical use of penicillin. And later on, Waxman and his colleagues found actinomycetes as a source of antibiotic. And nowadays, most of the antibiotics are the source from the actinomycetes. So these are the famous three names which you need to remember about the history of the antibiotics. If some pictures comes, sometimes it may comes in MCQs, in some quizzes. So you also need to remember about this small history. So this is the timeline of antibiotic. Why I have given is in this slide is that you can see the polymyxin was invented long back in 1950. We think polymyxin being a new antibiotic and is active against the resistant bacteria. But the thing is not so. The polymyxin was discovered long back in 1950. But the unfortunate part of the story is we are getting the resistant bacteria nowadays, which was not so prevalent before. So we are using polymyxin as a new drug, but this drug was invented long back. The antibiotic discovery has almost stopped at the time of 2000. No new antibiotics are generally being produced. All are the chemical derivatives of the old antibiotics. But day by day, we are getting newer organisms which are resistant to different antibiotics and classes. So coming to the division of the antimicrobial, it is divided according to the chemical structure, type of organism, bacterial, fungal, parasitic, viral, spectrum of activity, it may be narrow spectrum, broad spectrum, it may be cidal or static, and the sources is natural or synthetic. So coming to the more classification according to the sources, you can see nowadays the most of the antibiotic source is the actinomycetes. Other bacterial sources are the polymyxin, polypeptide, monobactams, and mupirocin. The fungal source is our famous penicillin and the cephalosporin, and the synthetically manufactures are the azoles, nitrofurans, oxalolidinediones, quinolones, and sulfonamides. So these are the classification according to the source of the antibiotic. These are the according to the activity, antibiotic, antiviral, antiparasitic, and antifungal. This is the classification, and which is most important for us is the different classes of antibiotic. So here what we will try to learn from this slide is which are the bactericidal and which are the bacteriostatic antibiotic. Before learning this, let us know site of mechanism of the antibiotic. So the antibiotic mainly act on three places. One is the cell wall and the cell membrane. One is the protein machinery, and another is the nucleic acid synthesis. The cell wall is mainly the point of action of the beta-lactams. So which are the beta-lactams? The penicillin, cephalosporin, carbapenems, and monobactams. Along with are the bacteriacin and the glycopeptide. The example of glycopeptides are vancomycin and teicoplanin. So vancomycin and teicoplanin acts on the cell wall. Phosphomycin also acts on the cell wall, which is not in this list. So you have to remember phosphomycin is an important antibiotic of in our ICU, we are using it on a regular basis. So phosphomycin also acts on the cell wall. For the membrane integrity, you have to remember these two famous drugs, polymyxin B and daptomycin. This acts on the cell membrane, causing pore into it. It's not acts on the cell wall. Now coming to the protein synthesis, there is a 30S and 50S. We used to, during our pharma days, we used to remember it by a mnemonic. What was the mnemonic? Buy at 30. So we will buy at. At is the aminoglycoside and tetracycline. TG-cycline is a part of tetracycline. Minocycline, doxycycline, TG-cycline are the part of tetracycline. So buy at 30, sell at 50. So we have to know the sell. So when we are saying it's sell at 50, so chloramphenicol, spell cell with C. So start with chloramphenicol. Now comes the macrolides. In macrolides, there is a erythromycin. So you get E and LL. Clindamycin belong to the group of lincosamide. So L and linezolid also L. So you have to remember C for chloramphenicol, erythromycin for macrolides, L for linezolid, L for lincosamide. So buy at 30, sell at 50. You can remember cells. So then S will stand for streptogramins. So it's very easy to remember. Buy at 30, cells at 50. And nucleic acid, fluoroquinones, metronidazole, and rifampicin is a very, very important MCQ. The mechanism of action of rifampicin, you have to remember. The mechanism of action of fluoroquinones, the questions comes again and again. And the metabolic pathway inhibitors are the sulfonamides and the trimethoprim. Now coming back to our previous slide. Classification of antibiotic according to the bacteriostatic or bactericidal. So what you need to remember, the antibiotic acting on the cell wall. So if you destroy the wall of the cell, then the bacteria cannot live. So the bacteria has to die. So if the bacteria is acting on the cell wall, then the drug become bactericidal. So let's take an example, beta-lactam. So what is written in the below? The reds one are bactericidal. The blue ones are the bacteriostatic. So the red one inhibits the cell wall synthesis. Third inhibits the cell wall synthesis. So if the cell wall synthesis is destroyed, then the bacteria become bactericidal. Whereas also if the DNA or RNA or the nucleic acid is destroyed, then also the organism becomes bactericidal, because if the wall of the house is destroyed, if the important machinery or the kitchen is destroyed, you cannot eat something, so the cell will automatically die. So if the nucleic acids are destroyed, as in case of quinolones, then and the cell membrane and the cell walls are destroyed, as in case of beta-lactam, glycopeptide, and lipopeptide, the cell will die. So it will be bactericidal. But if the drug is acting on the protein machinery, then the drug is bacteriostatic. As for example, you take the tetracycline, macrolides, oxalidindiones, in which is the example of linezolid. They are bacteriostatic because the protein machinery will halt for some time. Again, when it gets certain circumstances or certain environment, then it will again starts to grow. So it doesn't kill the bacteria, it stasis the growth of the bacteria. So cell wall, cell membrane, nucleic acid, cell gone, bactericidal. Protein machinery, static, the antibiotic is bacteriostatic. But it's all things, and all that glitters is not gold. So there is an exception. The aminoglycoside, being the inhibitor of the protein synthesis, is a bactericidal drug. So this is only and only exception. So if you get amikacin in the choice of your MCQ, then you have to tick it as a bactericidal drug. So remember, cell wall, cell membrane, nucleic acid, bactericidal. Protein machinery, bacteriostatic. Exception, aminoglycoside, amikacin, neomycin, streptomycin, kanamycin, and so on and on. And nowadays, the famous plasmomycin also. So this is the classification. Beta-lactams, mainly our topic of concern, it acts on the penicillin binding protein. It has two units, transpeptidase and transglycosylase. So there is a two bonds. The bonds between the peptidoglycan monomers or the subunits are the glycosidic bond, and the bond between the peptide chain are the peptide bond. So there is two unit of the penicillin binding protein. One is the transpeptidase subunit, one is the transglycosylase subunit. So beta-lactam binds to the transpeptidase active site and inhibits the transpeptidase enzymes directly. But the glycopeptide or the vancomycin are the large molecules. They bind to the DLR terminal of this peptidoglycan subunits, and they inhibit the transglycosylase enzymes to get attached and elongate the chain. So glycopeptide, vancomycin or targocid or ticoplanin binds to the DLR subunit of the peptide chain, and it prevents the elongation of the peptidoglycan chain. And the beta-lactams binds to the transpeptidase active site, and it's inhibit the formation of the peptide cross-linking and making the cell wall weak, and ultimately leading to the sidal of the bacteria or the death of the bacteria. So these are the bactericidal antibiotics. We have already read the mechanism of action of different antibiotic in different part of the protein synthesis machinery. Remember the mnemonic: buy at 30, sells at 50. You have to make profit, na? You will buy at 30, you will sell at 50, and then only you will be gaining out of antibiotic. Spectrum of the antibiotic, narrow and the broad. So what we will be focusing on, we will be focusing on the generation of cephalosporin. So what you need to remember at your resident level, we are not talking about here about at the consultant level. At the resident level, what you need to remember, the first two generation of cephalosporin are more prone to gram-positive bacteria. As the generation of the cephalosporin proceeds, it becomes active to the gram-negative bacteria. Again, when it comes to the fifth generation, then it becomes active against the MRSA or methicillin-resistant Staphylococcus aureus. So, if you are asked cefuroxime or cefoxitin in the second generation, in the first generation, cephalexin and the cefazolin, they are mainly active against gram-positive, but they are not against MRSA. They are mainly against the MSSA. They are most commonly used. We use Supasef. So these are the second generation of cephalosporin. So these are mainly used after a clean cut surgery or after a surgery, mainly where the skin is disrupted, then we use this first generation and second generation cephalosporin. But the third generation and the fourth generation cephalosporin, the most common feature of these is the third generation cephalosporin and the fourth generation of cephalosporin have an anti-pseudomonal activity. Not all. Ceftriaxone doesn't have anti-pseudomonal activity. Ceftazidime, cefoperazone, cefepime, these three has an anti-pseudomonal activity. You can see at the end or at the right hand side of the chart, the antibiotic that provides coverage to the pseudomonas are carbapenem except artapenem. Very important to remember, artapenem has no pseudomonal activity. Piperacillin tazobactam, cephalosporin, ceftazidime and cefepime, cefoperazone also has an anti-pseudomonal activity. Fluoroquinolone, ciprofloxacin, levofloxacin, aminoglycosides, and aztreonam or the monobactam. These antibiotics have only pseudomonal action, anti-pseudomonal action. So if you are thinking to cover an anti-pseudomonal organism, especially in the destroyed or structurally defective lung, the patient is admitted for a long time, patient is transferring from one hospital to the another, the patient is not getting better with the traditional antibiotics. So you should remember that you should be covering a Pseudomonas aeruginosa, or you should be covering with an anti-pseudomonal antibiotic, and these antibiotics are only and only active against the Pseudomonas or Pseudomonas aeruginosa. We also have the anaerobic are the clindamycin and metronidazole. But in normal patients, we don't need in a normal patient in an ICU, we do not need separately an anaerobic coverage for an aspiration pneumonia or something like that, because this piperacillin tazobactam, meropenem also have a good anaerobic coverage. When we are trying to cover Clostridium or some notorious anaerobic bacteria, then only we use metronidazole, as in case of the Clostridium difficile. Or in soft tissue infection, we need an antitoxin activity, then we use clindamycin. Otherwise, we do not generally use for anti-anaerobic agent in ICU separately with piperacillin tazobactam and meropenem. So this is also very important. If a patient comes to in ICU and you are suspecting an aspiration pneumonia, you add metrogel along with the meropenem. This makes no sense, because the meropenem and piperacillin tazobactam also have an anti-anaerobic effect, or has a coverage against the anaerobic bacteria normally present in our gut. So you don't need to add an anaerobic agent apart from this piperacillin tazobactam and meropenem. So again, we have some questions for you. Which of the following antibiotic acts on the cell wall? Answer is very obvious. Glycopeptide is there. So the teicoplanin acts on the cell wall. So you may thinking of the daptomycin, but daptomycin acts on the cell membrane. So these are the small tricks which you can get in the exam. So beware when you are attempting an MCQ, which is acting on the cell wall and which is acting on the cell membrane. Which of the following is not an anti-pseudomonal drug? Ciprofloxacin or fluoroquinolones is a pseudomonal drug. We have already read. Amikacin aminoglycoside is a pseudomonal drug. Aztreonam is a pseudomonal drug. Artapenem is a carbapenem is a pseudomonal drug. Oh no. Carbapenem except artapenem is a pseudomonal drug. So we have to remember, artapenem is not an anti-pseudomonal drug. It is very lucrative to use artapenem on an OPD basis because it's only OD or once a daily dose. But we should not use when we are suspecting a Pseudomonas aeruginosa in the growth. We are suspecting Pseudomonas growth in some tissues or somewhere. You should not be using artapenem. And also an exception or a condition where you should not be choosing artapenem as the antibiotic when the patient is suffering with hypoalbuminemia, because the artapenem is highly protein bound. So is the case with the teicoplanin or targocid. So if these are the highly albumin bound, so you should be very cautious. You should be using in a higher dose if you are using this drug in a patient with a hypoproteinemia, because most of the drugs will wash out with the kidney and very little will remain in the serum or plasma. So you should be very cautious in using artapenem or ticoplanin in a patient of hypoalbuminemia or hypoproteinemia? So answer is artapenem. Question 7, which of the following is a bactericidal antibiotic? It's linezolid, amikacin, clarithromycin, doxycycline. We have set the rule: buy at 30, sell at 50. Protein machinery, anti-protein machinery drugs, all of our anti-protein machinery, but the exception to the anti-protein machinery drug, all are bacteriostatic except aminoglycoside, and the answer here is amikacin. B, amikacin is a bactericidal antibiotic. So coming to the PK/PD of the antibiotics. So why we need a PK/PD of the antibiotics? Pharmacokinetics and the pharmacodynamics. These are the old pharma. We have left it in the second and third year of MBBS. Why today, again in the intensive care, we need a PK/PD of the antibiotic, the pharmacokinetics and the pharmacodynamics? The reason behind, if we know, if you have the knowledge of pharmacokinetics and the pharmacodynamics of the antibiotic, then you can use the antibiotic in a more smarter way. It preserves the efficacy of the existing antibiotic. It involves the use of pharmacology, clinical outcome, and microbiology to optimize the antimicrobial use, improve the outcome, and minimize the toxicity and resistance. Just you imagine a knife in a hand of child and in a hand of chef. What is the difference? The same knife in a hand of child is a dangerous weapon. In a hand of chef is a God-gifted weapon, which is very much essential for preparing delicious dishes which we go and eat at restaurants. So it's very important. A drug, if in a right hand, is a magical thing. If in a wrong hand, is a poison. So we need to know this PK/PD of the antibiotics before prescribing an antibiotic. So let's start the pharmacokinetics and the pharmacodynamics of the antibiotic. Coming to our old pharmacology, what do you mean by the pharmacokinetics and what do you mean by the pharmacodynamics? D for drug. So for pharmacodynamics means what drug does to the pathogen, not to the body, sometimes to the body, and mainly to the pathogen. So D is for drug. So pharmacodynamics, what drug does to the pathogen. Pharmacokinetics is what host does to the drug. Why? The K for king. Who is the king in this whole scenario? The host. So the K is for king. So the pharmacokinetics is what the king or the host does to the antibiotic is absorption, digestion, metabolism, and elimination. So these are the famous 3 steps: absorption, so not digestion, I am wrong over there, distribution, metabolism, and excretion. So we will be coming to this term one by one. So this is the process of pharmacokinetics. We should remember absorption, distribution, metabolism, and elimination. So this is the path by which the drug is absorbed, then it's got distribute, and then finally it got excreted, and ultimately what concentration or the minimum concentration which it's achieved is known as the trough concentration or the steady state concentration. We will be coming to those little later. Not a single dose always causes trough or steady state concentration. We need at least 4 half-lives or 5 doses. We will be coming later on. Don't skip over. We should not skip over to that at this position, but we should be remember absorption, distribution, metabolism, excretion, and finally we comes to a steady state level. Coming to the absorption, the weakly acidic drug which forms salts with the cation ionize more at alkaline pH. So the weakly acidic drug are mainly the strong basic drugs. So they form salts with the cations. So they ionize more at the alkaline pH and so absorbed better at the acidic pH. Why? If it is more ionized in an alkaline pH, the ionized particle will not pass through the lipid molecules, because if you need to get absorbed, you should pass through the lipid layer. So it remain unionized in the acidic pH, so it get better absorbed in the acidic pH. Whereas the weakly basic drug which forms salts with the anions like atropine sulfate, they conversely ionize more at the acidic pH. As they are weakly basic, so they are strongly acidic, so they ionize more at the acidic pH. And as they ionize more at the acidic pH, so they are better absorbed at basic pH, because at basic pH they are non-ionized, and absorption occurs better in case of non-ionized particle, because the non-ionized particle only passes through the lipid. The ionized particle passes through water. Ionized particles are the hydrophilic, non-ionized particles are the lipophilic. So it's very obvious that where the drug will be non-ionized, in that medium the drug will be better absorbed. So coming to the bioavailability. Bioavailability is the measure of the fraction of the administered drug that reaches the systemic circulation. So if you take a drug orally, so some part of it reaches the systemic circulation. If 60% reaches the systemic circulation, so the bioavailability becomes 60%. For an IV drug, it's already pushed into the systemic circulation. So the IV drug has a 100% bioavailability. So these are the acidic drug. Acidic drug are mainly binds to the albumin, better absorbed in the acidic pH, ionized in the intestine, because the intestine has a basic pH. So that it's become ionized in the basic pH. So it's better absorbed in the stomach. So we have already read that the acidic drugs are the better absorbed. So for acidic drug, take it as weak acidic drug, weak basic drug. So weak basic drug binds to the alpha-1 glycoprotein, better absorbed in alkaline pH. Where is the alkaline pH? Rich in bicarbonate, it's intestine. So the ionized pH is in the stomach because it's rich in hydrogen ion. So these you need to remember, acidic drugs are excreted quickly in the alkaline urine, and the basic drug are excreted quickly in the acidic urine, because the weak basic drugs are ionized in the acidic pH. As it is ionized in the acidic pH, it is hydrophilic. So if it is hydrophilic, it will go easily in the urine. So if we make the urine acidic, so the drug will be ionized. It will not be reabsorbed. It will be excreted quickly in the acidic urine. So for excretion of an acidic, weakly acidic drug like salicylic acid, we need to alkalize the urine. So this is the reason why the urine is alkalized in case of salicylic acid poisoning. The weakly acidic drug, more ionized in the acidic pH, easily excreted out, not reabsorbed. So the alkalinization of the urine is important in case of weakly acidic drug. These are the drug which is better absorbed with the food, impaired by the food. You can make a screenshot of this. So this is the reason why you prescribe some drug before the meal, and after the meal you can take the screenshot of this. Coming to the volume of distribution. The volume of distribution is the apparent volume of distribution, presuming that the body acts as an single homogeneous compartment. How it is measured? The amount of drug introduced into the blood divided by the plasma concentration. So if we give 1000 mg of a drug, and if we get a 50 mg per liter as a concentration of plasma, then by calculation we can say that the drug is distributed over a volume of 20 liter. But where is 20 liter in the body? It's not 20 liter. So the main thing is that it is known as apparent volume of distribution. So some part is distributed in the plasma, some part it goes into the lipophilic component, the fat compartment. Later it gets redistributed into the plasma. So this is basically a apparent volume of distribution. So what we can say, that if the drug is more lipid soluble, so it has a large volume of distribution, because if it's a lipid soluble, it will diffuse in the fat rich compartment. It will be less in the serum. So when we take the concentration of the serum, it will be on the lower side. And if the drug amount remains the same, and if you divide, the denominator is lower, then the volume of distribution will be very high. So if we get a lipid soluble drug, then the drug will have a high volume of distribution. Why we are reading in intensive care? Because in case of certain poisoning, or in case of certain situation, we need to dialyze the drugs out. So if a drug has a high volume of distribution, if the drug is lipophilic, if the drug is more soluble in lipid and it goes to the fat compartment, then by dialyzing, you cannot take the drug out. because it has a large volume of distribution. So the volume of distribution should be low if we need to dialyze the dialyze the drug. So the which drugs has a low volume of distribution? The drugs which are hydrophilic in nature, right? So factor governing the volume of drug distributions are these: pKa value, lipid water partition coefficient, degree of plasma protein binding is also an important part about how much the drug will be distributed to which compartment. Also, the difference in the regional blood flow is important, but what is more important is the lipophilic and the hydrophilic drug. Hydrophilic drug has a lower volume of distribution. Lipophilic drug have a higher volume of distribution. Remember, it's an apparent volume of distribution. So these are the example. Hydrophilic drug, see what I have said is a small volume of distribution. Obviously, it will be eliminated by kidney because kidney loves water. So hydrophilic drugs will be towards kidney, but what's bad part of it is a poor intracellular tissue penetration. So why we are reading PKPD? The hydrophilic drugs should not be used in case of pneumonia, in case of tissue infection, in case of soft tissue infection. So these are the bad choice for the soft tissue infection because it will not be distributed to the tissue. It is not a lipophilic drug, but it's a good for bloodstream infection. It's a good for urinary infection. So if I start using aminoglycoside for a pneumonia or a soft tissue infection, will it go to the tissue? It will go, but it will not go as like a lincosamides containing clindamycin. It will not go. Macrolides having azithromycin is better for the respiratory tract. Fluoroquinolones having levofloxacin, oxazolidindiones having linezolid, tetracycline having doxycycline. Now you think in the retrospective way that these drugs are mainly used for the pneumonia. These drugs are mainly used for the tissue infections. When we get a soft tissue infection, we go for linezolid. So these are the reason why the lipophilic drug has a large volume of distribution, primarily eliminated by the liver, and has a good intracellular and tissue penetration. Now you hope you understand why we are reading this PKPD, because this knowledge will change your whole concept of using an antibiotic. So not only the IDSA guideline, also this knowledge is equally important for choosing a proper antibiotic for a proper source. These are the same example, hydrophilic and lipophilic. Same thing is written again and again. Now coming to the metabolism. Metabolism has two parts, phase 1 part and the phase 2 part. The phase 1 is the non-synthetic phase. And the phase 2 is the synthetic phase or the conjugation phase. The phase 1 hydroxyl group or sulfhydryl group are being added or generated, and in the second part it is conjugated with the glucuronide conjugation of morphine, sulfate conjugation of minoxidil. So these things happen in the phase 2. So coming to the inhibitor and the inducer, why actually we are reading this? So these are the drugs which are very important for your daily practice. While prescribing a drug, we should remember whether it's an inhibitor and inducer. Let me give some practical example. Suppose a patient is on warfarin and the patient came with pneumonia. You prescribe clarithromycin. Next day, the INR comes to be 6. You may think the patient is on warfarin. INR is obviously it can go to 6. I will say the patient was warfarin for last 2 years. Then none of the time the INR climbed up. And why suddenly the INR climbed up now? Because you have given some drug which is inhibiting the metabolizing enzymes, and that is the clarithromycin. Now coming to the examples of azoles. In a liver transplant ICU, we give tacrolimus. We add voriconazole, we add fluconazole, we add voriconazole, and the TAC level goes very high. The next day you do a TAC level after 2-3 days and it goes very high. Why? Because the azoles of the inhibitors of the metabolic enzymes. So it's very important to remember which are the inhibitors and which are the inducers of the metabolizing enzymes of phase 1 and phase 2, especially the phase 2. So this is the reason why we need to remember the inhibitors and the inducers, because while prescribing a drug, you have to think of this. While you are prescribing an anticonvulsant, then you should increase the drug dose of the other drugs because they are enzymes inducers. They will increase the metabolism of those drugs, and the effect of the other drug will come down. When you are prescribing isoniazid, when you are prescribing carbamazepine, rifampin, so you should keep in mind about the inducer. So if you are prescribing an anticonvulsant, if you are prescribing an anti-TB drug, you should keep in mind about the enzyme induction and the failure of the action of the other drug. If you are prescribing clarithromycin and azoles, which is most common in ICU, also amiodarone, you should remember about the inhibition of the drug, and you should be expecting the exaggerated effect of the drug. The patient can land up into the TAC toxicity. The patient can land up into high INR due to warfarin because the inhibition action of the azoles or clarithromycin. Coming to the clearance, what do you mean by the clearance? Clearance is the amount of drug eliminated by the kidney in unit time divided by the plasma clearance during that time. That gives rise to how much of the blood is cleared of the drug in this unit time. So the unit of clearance is ml per minute. So coming to an example, suppose the kidney is excreting a substance 500 microgram per minute. The concentration during the inflow into the kidney was 10 microgram per ml, and in the plasma which is going out of the kidney, you think it's as a 0 microgram. It is totally eliminated. It's a pure clearance through the kidney. So per ml, the drug comes down by 10 microgram. So for 500 microgram per minute, the drug to go out of the kidney needs to filter 50 ml of the blood per minute. So the clearance basically is the amount of blood from which the drug is cleared off per unit time. So the clearance is the amount of blood from which the drug is cleared off per unit time. Clear? So this is the example, the creatinine. Now coming to the creatinine clearance. It is the volume of the blood plasma cleared of creatinine per unit time. We often measure creatinine clearance in our ICU. So the clearance rate of a given substance equals the GFR. So now coming to the creatinine clearance and the creatinine and the eGFR. So what happens? Creatinine clearance is slightly above or the GFR. Why? Because the creatinine is also excreted or secreted in the peritubular capillary. So suppose you are measuring how much creatinine is being cleared off the kidney. So whatever amount it is filtered in the kidney plus added to is the secretion of the peritubular capillary. So the amount of creatinine cleared off increases while you are calculating at the other end. So this creatinine clearance is 10 to 20% above the eGFR. GFR, what is GFR? GFR is the glomerular filtration rate. So this is equal to the clearance in most of the cases. Clearance is also that how much of the blood is filtered off that substance per unit time. GFR is also that. But how we calculate the clearance? The amount of total drug or substance cleared divided by the drop in the serum concentration, right? We have cleared in the previous slide. Now, when you are calculating the amount of substance excreted, it is something which is filtered out and something which is added by the secretion from the peritubular capillary, which is not calculated while estimating the GFR. So the creatinine clearance is 10 to 20% higher than the glomerular filtration rate. So you have to remember the creatinine clearance is 10 to 20% above the glomerular filtration rate. Now, this is very important, right? So creatinine clearance is calculated by which formula? The answer is Cockcroft-Gault CG formula. Coming to the first order, second order. So up to this, we complete our first part of the video. We will be starting our second part of the video with the first order, second order kinetics. We will be going to the pharmacodynamics. We will be going to the basics of the antibiotics in the laboratory, MIC, breakpoints, MBC, and the method of testing the susceptibility of antibiotics. And then we will be going to the IDSA or the ICMR guideline. And finally, we will be reading the antibiograms. So hope you like these lectures. So again, we will be meet in the next part of this lecture. Thank you.